All right, well, welcome everybody to our 13th Anne Klibanski Visiting Scholar lecture. My name is Louisa Sylvia. I'm the director for the Office of Women's Careers in the Center for Faculty Development. In today's session, Dr. Emily Methangkool from the University of California, Los Angeles, will be talking about cutting the Gordian knot, confronting challenges to patient safety in anesthesiology. Dr. Methangkool has disclosed her financial relationships noted on this slide, and there are no conflicts for today's lecture. So just a quick overview for anyone who's new to these series as well as to the award. This award was set up to really acknowledge some of the challenges that women were having during the COVID-19 pandemic, because women were disproportionately affected in regards to their ability to be able to travel and do talks and be able to sort of get out and collaborate with others and do some of the work that they had done prior to the pandemic. And so Dr. Miriam Berdella, who's our director of the Center for Faculty Development, had this great idea of starting this Visiting Scholar Award. And it is named after our president and CEO of MGB, Anne Klibanski, who's the former director for the Center for Faculty Development, as well as the former head of the neuroendocrine unit. And she's had leadership roles, the Harvard Catalyst, the Endocrine Society, and NIH. She's been extremely successful, not only as a researcher, but also in her work with supporting and advocating for women, and particularly in establishing really one of the sort of landmark awards here at Mass General, the Claflin Awards in supporting women faculty. So done some really wonderful work in support of our women faculty. And so these are our first visiting scholars, Anne Klibanski Visiting Scholars from 2020 to 2021. Hopefully people may recognize some faces there, an outstanding group. And here is our second group of visiting scholars. Again, you may recognize some of these faces of our women faculty across the hospital. But we've also teamed up with a lot of other institutions, such as University of California, to do this visiting lecture series. And there's UCLA right there in red. And this lecture series is a wonderful opportunity to bring together faculty members such as Dr. Methangkool to do talks here at Mass General. So it's a wonderful way to support women faculty, not only at Mass General, but across the nation here with other partnering institutions. And so we're really pleased to have her here as another bright women faculty member to hear about her area of expertise. And without further ado, I will introduce her. She serves, Dr. Methangkool serves as the Vice Chair of Quality and Safety for the UCLA Department of Anesthesiology and Perioperative Medicine. She's an Associate Professor in Cardiothoracic Anesthesiology. Dr. Methangkool is passionate about patient safety, quality improvement, cardiac anesthesia, and gender equity in medicine. She has written about and spoken on these topics at a national level. She's the current vice chair of the ASA Committee on Patient Safety and Education, and on the communications team for the Anesthesia Patient Safety Foundation. She's been active within the Society for Cardiovascular Anesthesiologists for many years and has served on the scientific program. She's the former vice chair of the Women and Cardiothoracic Anesthesia Special Interest Group and is a current member of the board of directors of the SCA. What a mouthful. She has been very busy doing lots of things, and I'm sure that is just a tip of the iceberg in what Dr. Methangkool has done. So with that, it's really my distinct pleasure to invite her to give her talk, and thank you again for being here with us. It's a pleasure to have you. Dr. Methangkool, take it away.
Thank you so much, Dr. Sylvia. It really is an honor to speak with you today. I'm just going to get my slides up to see if they will work.
Perfect.
Okay, great. Thank you so much, Dr. Sylvia. It really is an honor to speak with you all today. Today, I'm going to be speaking to you about the progress that we have made in patient safety in anesthesia, some of the potential emerging threats, and also some potential solutions. Dr. Sylvia did mention some of my disclosures. None of them are pertinent to this talk, except to mention that I am on the communication team for the Anesthesia Patient Safety Foundation, which is a nonprofit, multidisciplinary organization dedicated to improving research on and education in patient safety in the perioperative setting. So in this talk, I'm going to be reviewing a little bit about the history of patient safety in anesthesiology, discussing some of the underlying problems we still see in anesthesia patient safety, including the importance of having a healthy culture of safety as well as psychological safety, and then describing some of the current and emerging threats to anesthesia patient safety. So let's start off by reviewing a little bit of the history of patient safety in anesthesiology. I think all of you at MGH are probably very familiar with this picture. This is a demonstration of the first general anesthetic at Massachusetts General Hospital. If I had the chance to visit the Ether Dome a couple of years ago in Boston, and as an anesthesiologist, it really was a surreal experience. So this year is 175 years since Dr. William Morton first anesthetized a patient for a tumor resection all the way back in 1846. I think all of us can really agree that this was a momentous occasion in the history of anesthesia, but it was also a momentous occasion in medicine in general because the use of anesthetics really opened up the door to advancements in both medicine and surgery that have saved so many lives. But we also know that undergoing anesthesia is not without risk, and it was especially risky back then. The first recorded anesthetic mortality occurred in 1848, just 2 years after that first successful demonstration at the Ether Dome. So this is a depiction of Hannah Greener. She was suffering from an ingrown toenail. She received chloroform for an ingrown toenail removal and unfortunately suffered a cardiac arrest. 10 years later, the anesthesiologist John Snow, who is also credited as being one of the founders of modern epidemiology, he published a case series of 50 deaths related to chloroform in 1858. So although the risks of anesthesia were starting to be recognized, there was still very little that could be done about it. And in fact, there was very little progress in patient safety in anesthesia for the next 100 years, until 1954, when Beecher and Todd published this investigation into 600,000 anesthetics from 10 different institutions. And what they found was that 1 out of 2,200 perioperative deaths were attributed purely to anesthesia. But if paralyzing agents were used, the number of deaths jumped to 1 in 420. Even then, despite that sobering statistic, there was still very little progress until about the 1980s, when the issue of the high-risk nature of anesthesia was brought to the forefront of public consciousness. So this was a television program from 1982 that cited an error when a hypoxic mixture of gas was delivered to a patient. So the program opened with this following comment. So they said, if you are going to go into anesthesia, you are going to go on a long trip, and you should not do it if you can avoid it in any way. General anesthesia is safe most of the time, but there are dangers from human error, carelessness, and a critical shortage of anesthesiologists. This year, 6,000 patients will die or suffer brain damage, and the people you have just seen are tragic victims of a danger they never knew existed: mistakes in administering anesthesia. And then the program goes on to say that undergoing anesthesia is 1,000 times more dangerous than being in an airplane. So because of this public attention, the American Society of Anesthesiologists convened the Committee on Patient Safety and Risk Management. And around the same time, the various anesthesia chiefs at the Harvard teaching hospitals came together to discuss why their medical malpractice premiums were so high. Because at that time, it seemed that up to 1 in 10,000 perioperative deaths were caused by anesthesia. And these deaths were thought to be mostly preventable. So these chiefs created a risk management committee, and then they also proposed standards for monitoring during anesthesia. So things like making sure you know what the heart rate is, making sure you know what the blood pressure is, because before then there were no national standards for anesthetic monitoring. Because many of the members of that risk management committee were also very active in the American Society of Anesthesiologists, these standards were subsequently adopted by the ASA as national standards for basic anesthetic monitoring. And around the same time, Dr. Takeo Aoyagi received a patent for the modern pulse oximeter, which subsequently became a key component of the monitoring standards. So due to this combination in technology, including the ability to measure expired carbon dioxide, as well as these national standards, deaths attributed solely to anesthesia fell very rapidly. So if you look at anesthetic perioperative mortality, so in the 1950s, it was 1 death per 2,200 patients. In the 1980s, this fell to 1 death per 10,000 patients. And maybe in the 2010s, according to a recent paper, it is now 2.2 deaths per 100,000 patients. So this is due to both in the national standards as well as improvements in technology. So our national societies have been really instrumental in making these gains, especially with the establishment of the Anesthesia Patient Safety Foundation, as well as promotion of simulator education, as well as crisis resource management. Over the past couple of years, the ASA has also established the closed claims database, which looks at malpractice claims, the Anesthesia Quality Institute, and the National Anesthesia Clinical Outcomes Registry, or NACOR, all of which have allowed us a retrospective look into patient safety incidents. At the same time, medical errors in general remain pervasive. I think everyone knows of this report from the Institute of Medicine from 1999, where they say that up to 100,000 deaths per year in the United States is attributable to medical error. And in the past 20 years, I don't know that we've made too much progress. The British Medical Journal cited nearly 300,000 deaths in the US are attributable to medical error in 2016. And the WHO says that medical errors are the 14th leading cause of mortality worldwide, and that 1 in 10 patients in high-income countries have experienced some kind of medical error. So for anesthesiology specifically, those days where we have to do manual vital sign checks, where we have to check the heart rate or the blood pressure but manually, or those days where we had to work on these very old anesthesia machines without any alarms or without any double checks, those days are long gone. Anesthesia is a lot safer now, and people don't necessarily die from anesthesia itself, but people still do die from unsafe care, and people are still harmed by medical errors that happen in the perioperative space. So sometimes I often wonder whether we have become too complacent in patient safety, and especially too over-reliant on our previous successes and our previous history of patient safety in anesthesia. So for the next part of this talk, I would like to discuss why we still have problems with patient safety in anesthesia. And I do think that the problems can be narrowed down into a few specific categories. First, I do think we have to establish what it means by the term patient safety. So as defined by the Institute of Medicine, patient safety is the avoidance of harm to patients from the care that is intended to help them. In my work, both locally and both nationally, I feel that the most common problems facing our specialty are the following: problems with culture of safety, problems with medication safety, problems with non-operating room anesthetizing locations, as well as problems with clinician wellness and burnout. So I'll go over each of these topics in the next part of this talk. While the issues with non-OR and anesthetizing locations and medication safety are particularly germane to anesthesia, I do feel that culture of safety and clinician well-being do affect medicine across the board. And in fact, the Anesthesia Patient Safety Foundation agrees. Each year, they publish a list of the top patient safety priorities that should be addressed by our specialty. So as you can see here, culture of safety, non-operating room anesthesia, medication safety, and clinician safety are all on this list. The APSF actually holds a consensus conference each year where they provide recommendations on what to do next on a particular patient safety topic. In fact, this year, the conference was on clinician well-being, and in 2022, the focus will be on non-operating room anesthesia. So why do these areas continue to pose a problem for us in anesthesiology? So first, let's focus on culture of safety and what it means to have a healthy culture of safety. So safety culture is defined as an environment in which teamwork, clear communication, and openness about errors, both to other healthcare professionals as well as to patients, is paramount. And in fact, having psychological safety is a core component of having healthy culture of safety. So what is psychological safety? So psychological safety is the belief that the work environment is safe for interpersonal risk-taking, and it refers to the experience of feeling able to speak up with relevant ideas, questions, or concerns, and it's present when colleagues trust and respect each other and feel able, even obligated, to be candid. So concepts around psychological safety were really brought to the forefront of academia by your very own Amy Edmondson at the Harvard Business School. She initially did her work on adverse event rates in hospitals and found that, interestingly, teams that had better communication and better safety culture had more adverse events. And it was precisely because those teams had psychological safety, they felt comfortable reporting, that they were able to investigate those events. So how does psychological safety relate to patient safety? Sorry about that. The Joint Commission in its 2015 newsletter stated that the top 3 root causes of sentinel events in healthcare were human factors, leadership, and communication, all of which really relate intimately to issues of speaking up and psychological safety. So people don't speak up even when they have serious concerns. So this was a study of focus groups, interviews, observations, and survey data of over 1,700 respondents, including nurses, physicians, and other healthcare staff. And what they found was that 53% of nurses were concerned at some point about a peer's competence, but only 12% spoke up about it. Even worse, physicians are even worse. 68% of physicians were concerned about a physician's competence, but less than 1% spoke up about it. And even more concerning, 77% of nurses have experienced some kind of disrespect in the workplace, but less than 7% have spoken with that peer about this disrespect. And I think it's easy to understand why people don't speak up. So there are a multitude of reasons. One, they don't want to be seen negatively. Number 2, they don't want to embarrass or upset the people involved. Maybe they don't believe that speaking up will lead to any change. Maybe they spoke up in the past at significant personal risk and nothing changed. So they think speaking up will be futile. Why do it anyway? There is this very real fear of retaliation. Maybe they're uncertain about what they saw, and uncivil behavior can be a significant barrier in intimidating people not to speak up. Medicine is an environment where speaking up may be even more difficult because of a deeply ingrained hierarchical climate, perceptions about a superior's interpersonal skills, gender differences, and lack of adequate training in voicing concerns. This hierarchy may be especially felt with our trainees. So there is that special respect for the teacher-student or mentor-mentee relationship where they feel that speaking up is violating a special trust. There is also a high value placed on experience, and there is also concern about being negatively evaluated. At the same time, it's really essential to speak up when an adverse event happens, and it's important to have that psychological safety because when people have the ability to speak up when they see something, there is an opportunity for greater creativity, opportunities for better knowledge sharing. When an adverse event happens, if someone doesn't report, you really can't fix it. So this ability to participate in knowledge sharing leads to change and improvement for the organization. Specifically in healthcare, when people do speak up, besides improving patient safety, they also have a better work experience, they have better job satisfaction, and they also have an increased sense of responsibility and greater identification with their roles as physicians. So that brings us to the question of, we know that speaking up is important. We know that psychological safety is important in having a healthy culture of safety. So how can we encourage people to speak up and how can we promote that psychological safety? First of all, we have to address what doesn't necessarily work. Simply telling people to speak up doesn't generally work. Simply telling people to do anything will never work. Solutions really have to be embedded within the system. Telling people to speak up when they see a potential patient safety problem puts the responsibility on the individual without considering all those barriers that I listed before that individual has to overcome to say something, because speaking up really isn't in itself a natural act. So the system and the work environment really has to be primed to provide a psychologically safe environment. So how do we do this? So it comes down to systemic changes. So one of the best ways to encourage people to speak up is having a record of acting when someone does. Basically, that when concerns are brought up, they're addressed in an efficacious manner, an efficient manner, and that it's non-punitive and not retaliatory. Another way to encourage speaking up is by having anonymous reporting so that people have an outlet to share their concerns. You can also employ formalized teaching or simulation scenarios, but the results of that have been mixed, as we'll see. And probably the most important factor is having engaged and proactive leadership, because if you model open, honest, and vulnerable communication as a leader, other people will do the same. Education may have limited impact. We do have research with mixed results. So some studies have shown improvement in speaking up behaviors. Some studies have shown no improvement in speaking up behaviors. What is clear is that education by itself is probably insufficient for improvement, and that any intervention that you undertake probably has to be repeated at regular intervals or longer in order to be sustained. It is important to have really good leadership. So all of us are leaders, whether we're rounding on the floor or whether we are in the operating room. Even if we're just a trainee or if we're a faculty member or an attending physician, we are leaders. We lead by being an example to the nurses and other doctors in our areas. So how do we demonstrate healthy ways to speak up and encourage other people to do the same? So first is, you want to be humble. Admitting that you don't have all the answers really decreases that barrier to speaking up. Being vulnerable and open about our own mistakes will encourage other people to do the same. We want to be approachable, accessible, and invite input, and be prepared to listen for the good and the bad. We also want to engage stakeholders that we may not necessarily think of as having a stake. For example, our nurses, our medical students, or maybe the janitor who was there during the event, because they may have seen something that we didn't. And overall, we want to emphasize that errors are about learning and not necessarily about the specifics of the failure itself. So it's really important for leaders to set the stage, but there are things that we can do as individuals to make it easier to speak up. So first is recognizing that speaking up is a problem. It's actually hard to do, especially in the face of all of this hierarchy. But having a rubric in your head to follow, such as PACE, CUS, or the 2 challenge rule, can make it easier to speak up rather than trying to remember what to say in the moment. One of the most significant barriers to speaking up is lack of familiarity with team members and with the environment. And actually, this may be an unavoidable problem, specifically in anesthesiology, because we are expected to take care of patients with different nurses, different technicians, and different proceduralists every day. Because one day we could be on labor and delivery, the next day in the cardiac surgery OR, and the day after that in the GI endoscopy suite. So it's really important to familiarize ourselves with the environment, but also with the team members. And this is where simulation and team training can be really, really helpful. So having a rubric to follow in your head when needing to speak up can be really, really helpful. So there are multiple methods out there. I'll just talk about 3. One is PACE, or Probe, Alert, Challenge, and Emergency, which is best illustrated by this example. So first you start off with a simple question expressing your curiosity and giving the person an opportunity to answer. So you say, I thought we were operating on the left knee, not the right. If there's a lack of a response, then you start to escalate to the alert stage. So you say, Dr. X, we should be doing the left knee. So now you've transformed that question into a statement of fact. Again, if there's no response, you escalate the statement into a challenge. So you say, Dr. X, please stop. You are about to operate on the wrong knee. And finally, if there's no response or an unsatisfactory response, it's time to call for help. CUS is a similar method to PACE, involving escalating challenges to an unsafe situation. So first you start off with a statement of concern. Dr. X, I am concerned that you are operating on the wrong knee. If there's no answer, you escalate to the word uncomfortable. So you say, Dr. X, I am uncomfortable with what you are doing right now. And finally, if there's no answer, you escalate to the words safe or unsafe. And this really gets the attention of people in the room because nobody wants to be unsafe. Another rubric you can use involves similar challenges. So the 2-challenge rule was adapted from aviation crew resource management. So again, you start off with a question posing your opinion or your position or what you think should be happening as a question. And this allows leeway for the person to answer without becoming defensive. So your first challenge could be framed like this. I see that you have prepared heparin. However, this patient has a history of heparin-induced thrombocytopenia. Can you clarify your reasoning? If there's no response to the first challenge, then you need to be more direct and relate it to safety. So again, the word safe or unsafe really gets people's attention. And so you say, you are about to give heparin to someone who has documented HIT. I think this is unsafe. What do you think? So if there's no response to both challenges, then it's time to call for help. So these rubrics can be really helpful when witnessing an unsafe situation, but there are also a lot of little things that we can do every day to enhance communication. One good example from the operating room setting is the theater cap challenge. So this was a challenge that was created by Rob Hackett. It was spread throughout social media and basically asks you to write your name as well as your role on your script cap so that it's immediately apparent to everyone who you are and what your role is. And this can be really, really important in a crisis situation. Other ways to improve communication, as I mentioned, are simulation training, doing team training with various team members in the perioperative space, and it's also very important to have proactive leadership as well as a robust culture of safety. So psychological safety is an integral, crucial part of maintaining a healthy culture of safety. So what are some of the other components of safety culture? So one is recognition that medicine is inherently high risk, that despite that high risk, there is a dedication to patient safety, that there is the ability of everyone to report adverse events, errors, or near misses without fear of blame or punishment. And again, this is where having really good psychological safety within the organization is important. That there is engagement of everyone in finding solution to problems. And then there is a commitment on the part of the organization to providing resources to improving patient safety. So integral to a culture of safety is the way we handle adverse events. So in hindsight, when we are investigating these adverse events, we usually think this is how it happens, that there's some kind of event that leads to another kind of event that leads to a third event, and that leads to patient harm. But this is not necessarily how these things happen, because adverse event happens because there are multiple interrelated processes, diverging pathways, contributions from a number of different factors that result in patient harm. And it really isn't a linear pathway. So when we are thinking about trying to distill down into one particular root cause or one particular systemic issue, we really can't address what happened to the patient. So this is the usual approach to adverse event investigation. So you wait for something to go wrong, you establish what happened, you attribute actions to a person, whether it was a decision that they made or an action that they committed. You figure out what the root cause is, and then you make change to the system so the adverse event doesn't happen again. But I think everyone can see the inherent problem with this is that the approach to patient safety here is primarily reactive in nature rather than being proactive to prevent harm from coming to the patient. As I've mentioned, adverse events do not happen in a linear fashion, so it may be very difficult to establish what happened. Talking to the people involved will certainly help, but it also requires stepping back from the immediate events to think about how the different aspects of care intersect with one another and influence one another as well. The other problem with adverse event investigation is that it's so often attributed to a particular person, whether it was their action or whether it was their decision. But how adverse event happens is very complex, and our linear model doesn't represent reality. And this is in fact how patient safety is often taught, that there is this Swiss cheese model, that there are multiple incomplete layers of protection, that the last person in line is rarely enough to cause harm. And while this is true, true, what we need to do is focus on creating multiple overlapping layers of protection to decrease the probability that the holes will ever line and that harm will ever come to a patient. We have to also acknowledge that this person or this individual that's involved in the adverse event intersects with a multitude of different issues. And we have to think about how humans who are very fallible interact with a very complex systems and structure those systems, those interactions, and those intersections to improve patient safety. There is this very human tendency to blame someone when things go wrong, but this does not align with concepts of a healthy culture of safety or having psychological safety. Blaming or shaming individual physicians makes them less likely to report adverse events in the future and obviously will impact their psychological safety. Telling people to try harder or to be more careful or to read the label does not work because they know to do that already. Blaming someone does not prevent someone else from making the same mistake, and then education only weakly leads to improvement. At the end of an adverse event investigation, we often think about what was the root cause of the event, but this is not so simple to do. We often use this framework of a fishbone analysis to look at the different contributing factors, but what we often fail to see is that the factors are not necessarily independent of one another. They also intersect with one another and influence one another. So we have to have a holistic approach to this adverse event investigation. So while it's true that it's important to think of systemic changes to make so that adverse events don't happen, we honestly cannot ignore the fact that humans operate in these immensely complex systems, and we can never really engineer away the human factor from medicine. So what we need to do is focus on studying these intersections between humans and systems and where we can decrease the potential for harm in those interactions. So a healthy culture of safety relies primarily on having psychological safety, but it also recognizes the very important contributions of human factors, systems flaws, and the interaction between humans and systems in adverse events. So increasingly, this reliance on the traditional approach to adverse event investigation, which is often called Safety 1, and it's a retrospective look into analyzing why things go wrong. That framework is more often giving way to newer approaches to adverse event investigations, such as looking at why things do go right, or Safety 2. Thousands of times a day, patients go through a single hospital system without any adverse event or any patient harm. So what we need to do is analyze the vast majority of incidents where things do go right, learn from them, and apply them to processes or pathways that may be problematic. So in addition to culture of safety, what are some of the other areas that pose an ongoing threat to patient safety in anesthesia? So a huge area is non-operating room anesthetizing locations. So what exactly are non-OR locations and why are they a concern? And I think this may be a question those of you not in anesthesia may be wondering. So these are locations that are where anesthesia is provided outside of the traditional operating room setting. For example, the GI suite, where we do colonoscopies and endoscopies, interventional radiology, or the cardiac catheterization laboratory, where procedures like pacemaker implantations and arrhythmia ablations take place. So the term non-operating room anesthetizing location, or NORA, is also inclusive of things like office-based procedures like egg retrieval for in vitro fertilization. The growth of anesthesia care outside of the operating room has increased significantly in the past 10 years. So this is a great paper from one of our journals from 2017, showing that the percentage of cases we do in the operating room has decreased over time, while those that we do in the offsite locations has increased over time. And in the next 10 years, as procedures are becoming more minimally invasive and as sicker patients are becoming procedural candidates, this percentage is only going to increase. In fact, there are projections that NORA cases will comprise more than 50% of anesthesia cases in the next decade. Some of the characteristics of these cases are they are more likely to be started after 5 p.m., where there are fewer personnel, and also the personnel that are there are more tired. In fact, 16.7% of NORA cases are started after 5 p.m. compared to 9.9% of OR cases. Because many of these patients are not surgical candidates, they are much older and tend to be much sicker. And as technology has advanced, we are performing more high-risk procedures in these locations, even though they're still minimally invasive. It's really remarkable how medicine has advanced to the point where we are able to replace someone's aortic valve in the cardiac catheterization laboratory under sedation, not even general anesthesia, just under sedation. And in some hospitals, they can go home the same day. So it's really remarkable. Unfortunately, although there are a greater number of patients that are undergoing procedures in these interventional locations, they also face complications. So this was a study looking at 2 databases. So the pie graph on the right represents the American Society of Anesthesiologists closed claims database, which basically looks at malpractice claims. And on the left is the National Clinical Outcomes Registry, or NACOR, on the left-hand side. The left pie graph basically indicates the proportion of NORA cases by site. So you can see that GI cases comprise the vast majority of cases. But when you look at the malpractice claims, although GI cases are the vast majority of cases, cardiology and radiology cases are disproportionately represented in malpractice claims. And this may be due to the fact that, GI procedures may be less invasive. There are a lot of younger, healthy patients coming in for screening colonoscopies, for example. And just by the very nature of needing an intervention in the cath lab or in interventional radiology, you are probably older and sicker. Perioperative deaths related to anesthesia were disproportionately higher in the non-operating room locations compared to the OR, and then other common complications included aspiration pneumonitis and nerve injury. The mechanism of injury was commonly related to respiratory events, including inadequate oxygenation and ventilation. This may be associated with the fact that a lot of these interventional cases are performed with what we call monitored anesthesia care, or sedation, instead of general anesthesia. And what this means is that the patient does not necessarily have a protected airway in the form of an endotracheal tube or a laryngeal mask airway. And also, the ergonomics of these locations are not necessarily optimized for anesthetic care. For example, the patient may be located very far away from the anesthesiologist. They may not have access to the head, and the room also may be really dark because the proceduralists need to see the X-ray. So it may be very difficult to get to a patient when they are decompensating, and it may take a little bit longer to recognize when a patient is in distress. So again, although the proportion of temporary or permanent injury was lower in NORA locations, the proportion of deaths in these locations was much higher compared to the operating room. A lot of these claims were related to respiratory events, and 66% of NORA claims were judged to be secondary to substandard care, and 35% of them were judged to be preventable by better monitoring. So why are these locations associated with such significant complications? So as I kind of alluded to, the environment is not really optimized for anesthesia. The anesthesia machine may be on the wrong side. Very little space is allocated to the anesthesia team. The room is very dark. The patient is far away. The anesthesiologist doesn't have access to the patient's head. In addition, these areas are often physically located very far away from the other OR, sometimes even on different floors. So it makes access to additional personnel and additional equipment very difficult. And that can be a real problem in an emergency or crisis situation. The team members in these interventional locations, because they are not working with anesthesia providers all the time, they actually do their own sedation sometimes. They may not be familiar with what is needed to provide an anesthetic. And on the anesthesia side, because there are newer procedures happening all the time, we may not be familiar with what they are doing on the interventional side as well. And finally, there's a lot that needs to be done in terms of optimizing pathways and protocols on the organizational level that can improve patient safety in these locations. So in order to improve care in these areas, we have to make sure that communication remains robust amongst all team members. Again, having that psychological safety, working actively to provide team training is important. We have to make sure that we have the same standards in these locations that we do in the operating room, and that we also have to actively try to improve teamwork. So again, it comes down to having a really robust and healthy culture of safety. So in addition to non-OR locations, I think another huge problem with anesthesia patient safety is medication safety. So medication safety has been an ongoing problem in anesthesia for a really long time. And I think it was really brought to the forefront by this issue in lookalike vials. If you've been on social media and if you ever search hashtag anesthesia or hashtag patient safety, pictures of these lookalike vials will come up. And this is a problem that anesthesiologists can't seem to get rid of, because we are the ones who are doing the prescribing, the preparing, the administering, all without a double check. The problem is probably not going to change until we get manufacturers to align on the presentation of these vials. And although manufacturers do have to submit the presentation of the medication vial to the FDA, there is no federal mandate that medications of the same class have to have the same color coding. So if you look at these vials, you can see how easy it is to make a mistake, especially at 3 a.m. when you've been up all day, up all night, trying to take care of these patients. No matter how vigilant anyone is, this is a prime area where a mistake can happen. And in fact, medication safety has been getting a lot of attention in the lay press. So this was a news article that described how an anesthesiologist injected digoxin into a patient's spinal instead of a local anesthetic. The vials had somehow gotten mixed up. The anesthesiologist said that they were under a lot of pressure, a lot of production pressure, so they were in a hurry and they made the mistake. But you can also see how similarity of the vials also contributes to the error as well. This was a case series of 21 cases from 1960 to 2018 where a tranexamic acid was administered into a spinal instead of local anesthetic. In 20 of those cases, there were life-threatening neurologic or cardiac complications, and 10 of the patients died. And they cite the source of the error as a vial swap. And again, you can see how easy it is to mistake bupivacaine with tranexamic acid. This was a really tragic case of an 11-year-old who was undergoing a very simple debridement of an infected ankle. And towards the end of the case, the anesthesiologist had meant to give ondansetron, which is an anti-nausea medication, but made a mistake and administered phenylephrine instead. And that resulted in the patient suffering from a catastrophic hypertension and intracranial hemorrhage, and the patient eventually expired. And you can see how this happened. And actually, this picture was not from that hospital where this occurred. This picture is from my hospital. This combination of vials and this presentation is still out there across multiple institutions across the country, and we still haven't made changes. So this is still a pervasive problem. As you can imagine, there aren't any real randomized controlled trials on how to improve medication safety. We do have studies on simulated scenarios, and we do have consensus recommendations as such as this one that was published in the British Journal of Anesthesia. So when you think about improving medication safety, I do think that we can break it down into two areas. So one, at the local level, what we can do at our own institutions, and then what we need to address on the national level. So at our own institution, eliminating concentrated drug vials would be important. I think, if that anesthesiologist in the case of the 11-year-old didn't have access to concentrated phenylephrine, this may not have happened. Having pre-filled syringes, again, trying to take away the human element from both prescribing and preparing medications. And then standardizing concentrations is also important. At the national level, we really have to standardize drug vial appearances to eliminate the problem of lookalike vials, perhaps creating incentives for pre-filled and pre-diluted medications, again, to avoid that issue of the anesthesiologist preparing the medications, and perhaps providing some incentive or standards for barcoding of medications in the operating room may help as well. And last, but definitely not least, I'd like to discuss the issue of clinician wellness and burnout, which has become a crisis throughout all of healthcare. And I will say that the issue of clinician well-being could be an hour talk in and of itself, but I did feel that it would be remiss to exclude this topic from this talk because it has such a large potential impact on perioperative patient safety. The issue of burnout is tied in with a number of other issues, including burnout and depression, unprofessional behavior, the second victim effect, as well as patient safety. So this is a very recent national survey of nearly 4,000 anesthesiologists, and they sent out the survey in March of 2020, so before the height of the COVID pandemic. And what they found was that 59.2% of anesthesiologists were at high risk for burnout, and 13.8% actually had burnout. Contributors to risk for burnout include things like perceived lack of support at work, working more than 40 hours per week, LGBTQ or asexual status, as well as staffing shortages. My suspicion is that 2 years into the pandemic, these numbers are probably much higher now. The study is substantiated by a number of other studies in the literature. Other studies have found that anesthesiologists are very burned out and that residents may be at higher risk. Other factors contributing to burnout are production pressure, lack of control over schedule, as well as the high stress nature of anesthesiology as a specialty. And burnout has also been linked with medical errors as well. This was a study that basically looked at surgeons and found that 8.9% of surgeons made a medical error in the previous 3 months, and 13% of those surgeons attributed that error to being stressed or being burned out. Unprofessional behavior can also be a significant contributor to burnout. So this was a cross-sectional survey of over 16 hospitals and nearly 6,000 respondents that evaluated the effect of unprofessional behavior on safety climate, burnout, and depression. And they divided the respondents by quartile, where those hospitals in the first quartile had the fewest reports of disruptive behavior, while those in the fourth quartile have the greatest number of reports of disruptive behavior. So what you can see here is that hospitals in the first quartile had better safety climate, better work-life climate, fewer reports of burnout, and fewer reports of depression. So unprofessional or disruptive behavior can have a real impact on both patient safety as well as provider safety. The authors also looked into specific behaviors such as turning their back before the conversation was over, bullying, humiliation, hanging up the phone on someone, making inappropriate comments, or showing physical aggression. And what they found was that in settings with fewer reports of good teamwork, there was a higher incidence of disruptive behavior. And they also found that one or more of these 6 disruptive behaviors were witnessed by over 50% of respondents and reported in 97.8% of work settings. So what this means to me is that this kind of behavior is extremely pervasive, and because it's so pervasive, it must mean that it's tolerated to some degree. So this is a huge potential opportunity for improvement at the organizational level. Large-scale studies tying specific adverse events to specific disruptive behaviors are sparse, but there is evidence that there is a link. So this was a survey study of over 4,500 physicians, nurses, and other healthcare professionals, and over 50% of respondents believed that disruptive behaviors had an effect on adverse events, errors, patient safety, and the quality of care that was provided. In addition, a significant percentage of respondents also knew of specific adverse events that occurred due to disruptive behaviors. So these disruptive behaviors can have a significant disturbance on focus, concentration, collaboration, communication, and information transfer. And all of this can lead to potentially preventable adverse events, compromises in safety and quality, as well as patient mortality, and does have a significant effect on clinician well-being. In addition, issues with burnout, depression, and work-life imbalance can result in decreased provider performance, as can having an adverse event. So we have to acknowledge that healthcare providers who are involved in adverse events carry with them a tremendous sense of personal responsibility for that event. The second victim effect can result in things like guilt, anxiety, fatigue, anger, depression, self-doubt, burnout, and it also can lead people to leave the healthcare profession altogether. Some of the risk factors for development of the second victim include things like poor patient outcome, having a high level of personal responsibility, young, previously healthy patients or multiple patient lives, as we often see in the labor and delivery floor and in obstetric anesthesiology, being a female healthcare professional, as well as institutional handling of error and a culture of safety and disclosure. So having that robust, healthy culture of safety and having psychological safety can help mitigate some of the effects of second victim. Research on how to limit the second victim effect is limited. There was this one survey at a specialized pediatric hospital where they found that a non-punitive response to error can decrease the second victim effect. So again, it comes down to culture of safety. It's also important to have peer support as well. The second victim experience and support tool is a validated measure that can be used by organizations to assess the second victim experiences of clinicians after adverse events. And all of these responses are rated on a 1 to 5 Likert scale. At the University of Colorado, they have an unexpected event algorithm that provides guidelines on what to do after an adverse event, along with a peer support team. So they also have a clinical psychologist on staff who can consult with clinicians during this time as well. And similarly, at UCLA, we also have a peer supporter who is on call at all hours of the day, including weekends. And these peer supporters have been trained by a clinical psychologist on how to discuss adverse events and provide the support to clinicians who are experiencing these adverse events. So there have been a number of specific interventions that have been tried to improve physician and clinician well-being. What is clear is that targeting individual behavior, so telling someone to go to the yoga class or go to mindfulness class, is not that effective. What we have to do is look at systemic issues that can improve well-being as a whole. So what that means is starting with having that healthy culture of safety, maintaining and promoting psychological safety, recognizing that wellness and burnout are real issues, that unprofessional behavior should not be tolerated, and that supporting our providers during critical events is paramount. So this was a recent schematic that was published that describes some of the obstacles that institutions face in physician wellness, but it also provides a potential framework for targeted interventions at both the local and national level. So although the catastrophic failures that we saw in anesthesia in the 1950s through the 1980s, those are no longer present. Anesthesia is a lot safer now. There are still underlying problems that we have to address in anesthesia patient safety. And having a healthy culture of safety can help mitigate a lot of these threats. So thank you so much, everyone, for your attention. I really appreciate it. It was really an honor to be able to speak with you today. I'd like to thank my department and as well as my mentors, without whom this work definitely would not be possible. And I'd love to hear from the audience their comments and also get their perspectives on this issue as well. Thank you so much.
Great. Thank you so much, Dr. Methangkool. And what a whirlwind of excellent information as it relates to patient safety that really crosses so many different departments, and a wonderful talk. I certainly have a question, but if anybody does have a question, you can either put it in the chat or you can raise your hand or you can unmute and ask your question. But my question to you, I thought you did such a nice job explaining some of the challenges, and particularly how healthcare workers are part of a system, how we're not perfect to begin with, but then there's all these other constraints and things that are sort of that we have on ourselves as we're doing our work that contribute to this, including medications and how they're packaged, et cetera. My question for you is, do you know a department or a group that has implemented a sort of plan or approach that worked to improve patient safety that you could share with us? I know we don't have too much time, but any sort of case examples or...
Do you mean in terms of adverse event investigation or in terms of specifics like medication safety or non-OR?
Yeah, in terms of just being able to improve adverse events essentially in the OR, a group that sort of did something. Or I know you talked a lot about the importance of education and teamwork, but I just was wondering if there's any sort of specific example that you had offhand that you knew of. that people have
I think there's a lot of work happening in multiple different departments across the country in terms of how we approach adverse events. I think there has been a lot of focus on looking at the systems and trying to improve the systems in adverse events and taking the human factor away from that. As I mentioned in my talk, I don't think you can really ignore humans within the systems. And I think that it's a really complex topic to study, right? How do you improve interactions between humans and systems? So I think there's still a lot of ongoing work. Our previous approach to adverse event investigation, where we always talk about, let's see what went wrong, let's try to figure out at what point in the system this thing went wrong. I think there is increasing focus now in the past, probably 3 or 4 years, of looking at how things go right. But I don't think that that approach is necessarily widespread at the moment. It is being talked about in our anesthesia journals, but I do think that it could bear some repeating and more systemic nationwide spread as well.
Sure. So you have a couple of questions. Miriam.
Thank you, Emily. This was fantastic. So impressive, because you really covered so many different areas. And I want to talk about the psychological safety. So I'm a radiologist and I do a lot of intervention. So we do team training, and we, the SBAR, and that everyone in the team, our technologists, are the same. But then I go to do a procedure and we all go through the training, and then the technologist sees something and really doesn't dare to speak up. And I don't think it's because they're afraid that the attending or like me say something, but it's still this barrier, although we're talking about it. And so what can you recommend to really drive it home that it's okay for the nurse or the technologist to say, hey, you touched the II, change your gloves, or I saw something. I still have the feeling, despite everything we're doing, they're not getting through. So is there anything you can recommend?
Yeah, I think, a lot of the approach of a lot of institutions is to say, like, especially like at least at my institution during our timeout, we say anyone at any time can speak up if they see a patient safety concern, but then no one does, right? Yeah, exactly. So I think part of it is also being an example or exemplifying that behavior. So what I often try to do is try to engage the people that may not necessarily want to speak up. So I always say, nurse so-and-so, and always address them by name. Like I always try to make sure to know the name of everyone in the room. So nurse so-and-so, does this look okay? Does this positioning look okay? Like I always make sure to include them in all of the things that I am doing to make known that I value their opinion. So if you make it known that you value their expertise, you respect them, I think that gives them a little bit more impetus to speak up, because they see you more as colleagues rather than as operating within a hierarchy.
I love it. I'm going to do this tomorrow when I do procedures. I will make sure I address them and involve them more. Thank you so much. And again, it was fantastic. And just to say something, Louisa, we just had a session on a workflow and innovation, and Karen Nanji from MGH actually worked on something to provide more safety for medication administration within the OR, which can be quite random and not very safe. So she designed a system. I can send you, I think she's published it also.
Oh, yes.
But there is a lot of work that's done to improve workflow and make it safer.
Yeah, that would
be. But thank you again.
Thank you.
I will send you it.
That's great. I know we're running out of time, but Teresa, did you want to ask a question quickly here before we wrap up?
Can you guys hear me okay?
Yes.
Okay, sometimes my audio doesn't work. So I do a lot of peer support for the department, and one of the things I'm really worried about is the impact of the pandemic. And what we're seeing is people have never had to deal with things like being, the capacity issues are overlaying all the stresses of the pandemic, and then being angry with patients, things about not getting vaccinated, not believing in the science. People have never had to deal with that kind of stressor before. And do you have any strategies that have been really successful in terms of supporting people emotionally, psychologically, mentally through what is going to be, I think, a really awful couple of years?
Yeah, I totally see that at my institution as well. I do think that the human connection is what has been missed during this pandemic. As you can see, we're all, taking our meetings from Zoom calls. Even within my own department, we do all of our meetings via Zoom. So you miss that human interaction with your fellow colleagues. So I think this is a huge opportunity for the peers within the same group to provide support to one another. So maybe having regular debriefing sessions, regular therapy sessions with one another, trying to, discuss difficult cases that have happened. I think that can definitely be an area that can help improve those feelings as well.
Excellent.
Thank you.
Presentation. Thank you.
Yeah, so crucial, such an important topic. I know we have to wrap up, but thank you again for presenting today and for such a great talk. We really appreciate it.
Thank you so much. Thank you so much, everyone.
Take care.
Thank you.
Thank you.
Bye.